afternoon. I am Laura Dominguez, Assistant Professor of Otolaryngology and Laryngologist at University of Texas, San Antonio. And this, a little bit further back, this is my partner in crime, Dr. Blake Simpson. He is, okay, let's step back for a second. There we go. Hello. How are we? There we go. Okay, so Dr. Blake Simpson, professor and director of the UT Voice Center in San Antonio. And we are thrilled to have so many of you here in your post-brand deal state for this exhilarating lecture on everyone's favorite topic, chronic cough. And these are our disclosures, nothing directly related to this lecture. So I know all of you are dying to know what a day in the life of an assistant professor of otolaryngology is like. And this is it, folks. A lot of cough patients. And with every cough consult, the emojis just get a little bit more pathetic because it can be really frustrating to deal with these patients because some of them have been seeing doctors for years, they've been coughing for years, and they are looking to you to give them the answer and to give them some relief. So the goals of the lecture today are, number one, to give you a systematic way to approach the complex chronic cough patient, talk about the different treatment options based on the suspected etiology, and the reason why probably a lot of you are here to talk about a new form of treatment for chronic neurogenic cough, the superior laryngeal nerve block. This is something that we've been doing in our practice now for about 4 to 5 years, and it really has helped a lot of patients and really transformed our practice. So let's talk about some cough stats. Incredibly common problem, affects up to 30% of the population and accounts for about 3% of US ambulatory visits, which is a crazy number when you think about how many people go to the doctor every day. Over $3 billion a year spent on over-the-counter cough medications, and no wonder. I mean, look at all the different things that can result from chronic cough. Sleep disturbances, incontinence, even rib fractures. So overall, just a decreased quality of life. And so cough has been around for a long time, and it turns out that people found out what the cure for cough was a long time ago, and the answer was heroin, apparently. And believe it or not, it was promoted, I kid you not, as the non-addictive substitute for morphine. And, it was marketed by, a couple companies, even Bayer, the aspirin company, and they actually stopped marketing it in about 1910 because they found out that it was heroin, and it was quite addictive. So they actually were concerned about, patient safety, and they only recommended 5 to 10 drops in patients 3 years old or younger, as opposed to the full teaspoon that was recommended in adults. So, but don't judge too harshly because, maybe 100 years from now, people might think it was crazy that we were prescribing tramadol and Tussinex, right, for chronic cough patients. So, cough is basically a reflexive action to clear the respiratory tract. We can see here we've got an epithelial lining, and these little red receptors represent cough receptors, TRPV1, CGRP receptors, very hot in the pulmonology literature, targets for treatments for cough treatment. A new receptor that you all are going to hear a lot about in the coming years is the P2X receptor, P2X2, P2X3. There are some clinical trials going on right now with our pulmonology colleagues, and looking forward to see what they're able to come up with regarding those cough receptors. So these receptors are triggered by some sort of irritant, whether that be a fume, mucus, particle. It leads to release of histamines and prostaglandins, and ultimately a cough to clear the respiratory tract. These receptors are scattered throughout the aerodigestive tract, even some in the nasal cavity, some in the pericardium, and fortunately or unfortunately, however you want to look at it, for us, a lot of these receptors are concentrated in the larynx and in the tracheobronchial tree, which is why otolaryngologists and pulmonologists end up seeing a lot of these patients. So this is a typical consultation pyramid for the chronic cough patient, and primary care physicians, thank goodness for them, are dealing with a lot of these patients. They're catching the more obvious sources of chronic cough, like people who have ACE inhibitor-induced cough, which can, believe it or not, happen in up to 20% of patients, and it doesn't necessarily start right away. It can happen even up to a year after starting the medication. So if the patient says, my cough didn't line up with the time I started my ACE inhibitor, I still go ahead and ask them to stop it, do a trial off of it, just to see if it does help their symptoms. And it can take several weeks to improve off of the ACE inhibitor, so give it some time to see, if once it gets out of their system, if the cough improves. Usually we would like them to go see a pulmonologist next, but the, subspecialists here, this sometimes gets a little bit blurred, and sometimes they end up coming straight to an otolaryngologist. But after they see all the subspecialists, if we can't figure out what's going on, we will send them to the person who can actually help them, the speech and language pathologist, for cough therapy. And this is a typical chronic cough algorithm, fairly reputable journal, New England Journal of Medicine, so pretty good. And we're starting out with, the more obvious things. Like I said, ACE inhibitors, primary care physicians are ordering, chest x-rays and whatnot. And then we start moving on down our referral algorithm. So asthma, reflux, sinus disease, so that's where pulmonologists, GIs, ENTs come in. Then we start doing more, invasive things, bronchoscopy, maybe CT scan, and then we start moving into the idiopathic or neurogenic category. So like I said, this is from a medicine journal, so it's very wordy. I don't like a whole lot of words. I'm a surgeon, so I need basic things. So this is my algorithm, a lot more basic than the previous, but it essentially sums up the same thing. So cough patients can be broken down into, these etiologies for the most part. So when you are doing a history and physical on one of these patients in your office, you want to make sure that you are addressing and potentially treating the big three. And these account for about 80% of all chronic cough etiologies: upper airway cough syndrome, asthma, gastroesophageal reflux disease. And then, only then, when we eliminate these three, then the patients can be considered idiopathic or neurogenic in etiology. So let's start out with the most common source, upper airway cough syndrome. And this can be a little bit difficult to diagnose. There's no really, objective test. There's no pathognomonic finding. We just go based on what the patient's describing. Usually they'll say, I just have a little bit of drainage, postnasal drainage is usually what they say. Maybe some throat clearing. You might see some cobblestoning like we see here. And if you're really lucky, you might see some mucoid secretions actually draining down into the pharynx. The proposed mechanism of how this happens is, one, either we have mechanical stimulation of the cough receptors, or number two, the patient may just have increased sensitivity of those cough receptors. They're just upregulated. So how do we treat these patients? If it's allergic in nature, allergic rhinitis, avoidance of allergens, so obviously we need to know what is triggering them. So we'll send them for allergy testing so we can figure out what allergens could be causing the cough. Antihistamines and decongestants as well. If it's non-allergic in nature, these patients are typically going to respond a little bit better to older generation antihistamines, the ones that cause, sedation and dry mouth, all the things that we don't like. And decongestant as well, plus or minus an ipratropium bromide spray. Post-infectious patients as well, older generation antihistamines with a decongestant. Sinusitis, we're ENTs, so for those of you who are doing sinus surgery, this is our sinus surgeon, Dr. Philip Chen, but we, will go ahead and treat them with antibiotics, nasal steroids, and if you find sinus disease on imaging, then by all means go ahead and treat their sinus disease. So moving on to number 2, asthma. Now these patients will typically have cough that worsens with cold, exercise, and at nighttime. That's pretty classic. But there are a subset of patients where cough is their only symptom. They don't wheeze, and it can be up to 60% of patients, and these are the so-called cough variant asthma patients. And this video isn't necessarily an asthma patient, but just as a reminder to us all, we have all seen a patient who's referred to us with cough and wheezing, and they've been given the diagnosis of asthma, right? So this patient, we can hear she's wheezing, she's coughing.
White into many beautiful colors. These take the shape of...
So this is a bronchoscopy in clinic, and we can see that she doesn't have asthma at all, right? This is a tracheal stenosis that she acquired from intubation. So just keep that in your differential as well. But back to the cough variant asthma patients. So this is what a typical PFT profile is going to look like. They are going to have normal baseline PFTs, but they will have bronchial hyperreactivity. So in response to methylcholine challenge, they'll have a decrease in FEV1, and they will respond to bronchodilators. So these patients are typically treated with a corticosteroid inhaler and a bronchodilator, plus or minus a leukotriene receptor antagonist. Now, non-asthmatic eosinophilic bronchitis, it's not as common as cough variant asthma, but still I think about 10% of patients, they say, can have this entity, so it's worth mentioning. And this is a little bit different. These patients don't have any bronchoreactivity, no response to methylcholine challenge, and no response to bronchodilators. So how do we diagnose this? Well, this is diagnosed based on sputum eosinophils, and if you look back at the algorithm from the New England Journal of Medicine, you'll see that on there. For patients who have greater than 3% non-squamous sputum eosinophils, or they have an increased fractional exhalation of nitric oxide, then you may suspect this entity. But you really can't give them that diagnosis until you do a corticosteroid inhaler trial for a good 4 to 8 weeks. If they respond and they have some of that diagnostic criteria, then you will give them diagnosis of eosinophilic bronchitis. Gastroesophageal reflux disease, everybody's second favorite topic. So theories of how this causes cough. Number one, we can have potentially microaspiration, or number two, we can have activation of a reflex arc. Remember, we saw all of those cough receptors scattered in the aerodigestive tract. So there's a theory that there's an esophagobronchial reflex arc. And non-acidic reflux can cause cough just as much as acidic reflux. The true gold standard for diagnosing reflux would be impedance with pH monitoring, and impedance helps detect changes in resistance caused by liquid gas liquid or gas in the esophagus. And in combination with pH testing, you can see if symptoms are related to acidic or non-acidic reflux. So how do we treat these patients? These are the recommendations from the American Gastroenterological Association. And for patients who have complicated GERD, meaning they have erosive esophagitis or they have esophageal stricture, you're going to want to put them on a PPI for short-term healing and long-term symptom control if necessary. So again, if they're symptomatic or if they, say, have Barrett's, you can keep them on a long-term PPI. If they need it, keep them on it. If they don't need it, if they have uncomplicated GERD, no strictures, no erosive esophagitis, then try to wean them off of it. If the patient doesn't respond to a 3-month trial of a PPI, or you can't wean them and you haven't done formal reflux testing, then go ahead and consider doing that. So that way you can send them for reflux surgery or bariatric surgery if necessary. So we obviously want to try to wean people off of PPIs because there's a lot of controversy right now about acid suppression medication. And these are from a paper from Mayo Clinic Proceedings. And the things that they think are likely linked to long-term PPI use are on the left-hand side of the screen. Hypomagnesemia, a 43% increased risk in one meta-analysis that was done with long-term PPI use. B12 deficiency, we know obviously B12 is important in absorbing dietary proteins in the ileum, so 65% increased risk of deficiency with 2 years of PPI use. Small intestinal bacterial overgrowth just from changing the flora in the GI tract. The ones that are not so clear are things like osteoporosis, proposed by decreased calcium absorption, chronic renal disease, and then dementia. So the dementia study that they didn't really control for certain risk factors like alcohol abuse, hypertension, so we can't really say for sure if that's linked. So what does the AGA recommend in terms of prevention? They don't recommend routine use of any probiotics just for the sole reason of being on a PPI. They don't recommend doing calcium, B12, or magnesium over just the standard RDA guidelines. And this is different from what I said last year. If you guys came to our lecture last year, they actually don't recommend routinely screening creatinine or vitamin B12. At bone mineral density, you would just do it per normal national guidelines. If a patient is not symptomatic, then you don't need to be routinely screening these patients. By all means, if they have some sort of symptom of hypomagnesemia like muscle contractions, or if you think they may be anemic, then go ahead and order these labs, but otherwise not really necessary. So I don't know if you all saw, I think it was a few days ago that it came out that H2 blockers or ranitidine has carcinogens in it. Yeah, so if you all haven't received any phone calls from your patients yet, they're coming. Probably be waiting for you when you get back to your practice on Monday. So what do we do as an alternative for these patients who can't be on PPIs, don't want to be on an H2 blocker? Well, we have a good alternative in sodium alginates, and these are derived from brown seaweed, so it's nice and natural, and patients, like it if they don't want to be on a prescription medication. And alginates form a raft, and potassium bicarbonate in the substance reacts with stomach acid, and the CO2 bubbles actually get trapped in the raft and causes it to float to the top of the stomach. So the bottom picture is just plain Gaviscon. So you can see it's actually accumulating at the bottom of the flask. The top picture, the red one, is Gaviscon Advanced. So you want to recommend the advanced version because we can see it floated to the top, and now it's actually blocking things from refluxing back up the flask. So it works very differently than acids, PPIs that just decrease acidity of what's being refluxed. So a pretty nice alternative for patients who don't want to be on prescription medications. Again, these are over the counter. You can order them online. Generally, I think Gaviscon you have to order from the UK. So, believe it or not, these are actually the patients that are a little bit easier to treat, and that we can actually give them a diagnosis. But there are patients that we all see them in our clinics, patients like this, who come in and are constantly throat clearing and aggressively coughing throughout the entire visit. So what do we do with someone like this? So this is someone who I consider more to be on the irritable larynx spectrum, and we all see different versions of it. Some patients just have globus, cough, they may have muscle tension dysphonia, paradoxical vocal fold motion. So, it just can be very frustrating for us to treat these people. And this is a patient who I was scoping in clinic who actually was having, cough and like PVF at the same time. I actually did take the scope out at one point and gave the patient a straw and tried to help him through it, but this is when bringing in a speech pathologist can be really helpful. And cough suppression therapy is kind of our go-to if all else fails. And sometimes it actually is really helpful in combination with other forms of therapy. So our speech pathologist will counsel them on things like vocal hygiene, awareness of triggers, and certain suppression techniques. So this is not political in any way, but you can just see that she's having a coughing fit in the middle of a speech, which can be really awful for patients who do public speaking or professional voice users. So things like cold water, nasal inhalation, hard swallow are just kind of some of the things that our speech pathologists will teach patients to do to help kind of minimize their symptoms or control their symptoms. Okay, so we talked about horses now, and let's talk about the zebras. Pertussis can appear like the common cold, but you can get a cough, 1 to 2 weeks later. So ask about vaccination status. Tdap vaccine is recommended in adults. Aspiration, we talked about microaspiration, which can happen, or you can have gross aspiration, like in this patient. This patient has no topical anesthetic. This is just his baseline. Very atrophic vocal folds, very wet, wet voice, and this is what was causing his cough. But it may not always be this obvious, this severe atrophy. Sometimes it'll be a little bit more subtle, which is where video stroboscopy can sometimes be really helpful to try to assess glottic competency. If you don't have a strobe, but you have a speech pathologist, you can send them for acoustic and aerodynamic measurements, and they can look at things like aerodynamic resistance and airflow to let you know if they have glottic insufficiency. So things like voice therapy, injection augmentation can be used to treat glottic insufficiency. Dr. Sulika actually published a paper on utilizing injection augmentation for chronic cough patients, and they had good success in their series of patients. And the theories behind this is that it, either decreases microaspiration, or it could potentially be decreasing shortness of breath with speaking, which can also trigger cough. It might be resetting the sensory pathway, or it could be a placebo effect, right? I went to a cough conference a couple of months ago, and I presented, unfortunately, to a bunch of PhD pulmonologists, and telling them about, some of the things that we do as surgeons. And, they said, well, you're not doing randomized placebo-controlled trials, and maybe, some of the effect is just placebo, which might be the case, but do we really care? Probably, not really, right? If it gives the patient, we do care, but if it's giving the patient some relief, I think it's worth trying, because we have to try something when they've been to every physician they can think of. And of course, there is the psychogenic or behavioral cough, again, which, sometimes the nerve block, which Dr. Simpson is going to talk about, I feel like it does help with some of those patients to an extent, and sometimes in a combination with voice therapy or maybe some neuromodulators. So with that, I'm going to let Dr. Simpson take over, and he's going to talk to you about the different category of patient, the idiopathic or neurogenic chronic cougher.
There are a lot of seats up here. I see a lot of you in the back. If you want to come up now while we're switching slides and sit up here, they are available. Oh, thank you, Laura.
Yep. Do you want me to start? I can start your timer.
Sure.
Okay. There you go.
Turns out I have cough today. I think it's mucus. Got to do something about that. So I'm going to talk about neurogenic cough, which, at least in my practice, is the majority of the patients I see have that. They've usually been screened. They've had the big three treated. And so we see a lot of it. Neurogenic cough is thought to be an excitatory sensory neuropathy. And it was first described by Millen Amin and Jamie Kaufman in 2001, and also by Pete Kwu, who I saw in the back here. I don't know if he's hiding, in 2006. So it's we've known about it for a while. It's classically a diagnosis of exclusion, though I will tell you a lot of times when I see these patients, they may not have had everything else ruled out. It just looks like neurogenic, so sometimes I'll treat them without all the big three treated, but technically it's a diagnosis of exclusion. And when to suspect it is if they have an onset after a URI, or if you know there's an injury to the sensory pathway of the larynx, and certainly if they're not responding to other treatments. And most of these patients will have had a long duration by the time you see them in terms of how long their cough's been there. So symptoms that suggest neurogenic cough, and this is a classic one, is the patient that comes in and says, I have a tickle in my throat. Sometimes they describe it as an irritation or dryness. I hear that one a lot. I feel this dryness in my throat. And it comes on before their cough. They know it's coming. The triggers, there are many triggers that can be present. The classic ones are listed here. Talking, laughing, and singing, we'll see that a fair amount. Temperature changes, usually breathing in cold air. Positional changes of their body or head, odors, perfumes, chemicals, and then sometimes even touching a specific spot in their neck. Our first line of treatment for these patients tends to be neuromodulators, and the idea is they modulate the neural pathways within the cough circuitry and really just reset the threshold. They raise the threshold so it takes more stimulus to trigger a cough. And there's a number listed here, and I'll go through each one one by one. This is my favorite for neurogenic cough, is Elavil. I like it because the side effect profile is better than a lot of the other ones. And so there has been actually a prospective randomized control study done. It was published in the Laryngoscope in 2006, and they looked at Elavil 10 milligrams at night, and that's when I typically will give this, versus codeine and guaifenesin. And the Elavil group, the vast majority had improvement in their cough, more than 50%, compared to a pretty small percentage in the control group. And Bob Bastian, the same year in the White Journal, actually reported similar findings, although he noticed some patients, when they took them off the Elavil, continued to have improvement in their cough. In terms of the dose, I start at 10 milligrams QHS and will go up every week. I'll have them take another 10 until they get up to, usually I stop them around at 60. If they haven't responded to 60, I'll stop. But some people go up all the way to 100 milligrams, and you just get them 10 milligram tablets. Be aware of serotonin syndrome. I've not actually seen this, but just know that if your patients are on SSRIs and you start them on Elavil, they're at risk for this. It can start pretty typically soon after they begin the medication. And this is actually the Libby Zion case. I don't know if you're familiar with that. That's what she had. But they'll have high body temperature, agitation, tremor, and sweating and myoclonus. It can actually lead to unconsciousness and seizures and death. So it can be life-threatening. So just be aware of that. This is probably my second favorite neuromodulator that I'll use for cough, and that's Tramadol, or Ultram. Greg Dion, a colleague of ours in San Antonio, actually published in the White Journal a couple of years ago on this, and the dosage is 50 milligrams TID. It was a small series, and they looked at the cough symptom index, or the CSI, which you'll see this mentioned in a few studies. And the response rate was pretty good, 70%. A lot of these neuromodulators or treatments we have are about 60 to 80% effective for neurogenic cough. And the mean CSI score is improved down to 14. So it's not eliminating cough in a lot of these patients. Sometimes it does, but a lot of times they're better, and sometimes that's all we can really ask for. There is some patients that get somnolent, so just be aware of that. And a lot of times they can reduce the dose to once a day or twice a day. And there is a risk of drug dependence, of course, and serotonin syndrome as well. Gabapentin is a popular drug for neurogenic cough. I'm not crazy about it, but there's a good randomized double-blind placebo-controlled trial. We don't tend to do that in our field a lot. And it was gabapentin versus placebo, and you can see the dose range is pretty broad, right? And so a lot of people start out 100 milligrams TID and then just ramp up, and you have to ramp the drug up. You can't start right at the top dose. That's one of the reasons I'm not crazy about it. And in this study, it was 10 weeks of treatment, so it was a week ramp up, 8 weeks of treatment at the highest dose, and then a week going down. And they showed improved cough-specific quality of life and cough frequency compared to placebo. And this is what I don't like about it, is the last thing listed there is adverse reaction. About a third of patients will get sort of fatigue, dryness of mouth, dizziness, confusion. It's not well tolerated. Now, if you stay on it, some people will get over this, but a lot of people will come back to you, patients will come back to you and say, I just can't take this stuff. Lyrica is related to it. It's the prodrug, and there's another study. It's a retrospective study by Stacy Hallam, but it is another drug you can give. I think it's a little bit better side effect profile than gabapentin, and there's the dose there, 75 milligrams. That's usually what I would start out with BID, but you can go up to 150. These patients, again, about 80% of patients got better in this study, and it may be tolerated a little bit better because it's lower milligram, and there's no ramp up. So if I'm going to use gabapentin or pregabalin, I would use pregabalin. There's others. I haven't used these very much, but they're in the literature. Baclofen, 10 milligrams TID. It's just based on a case study. There's not a lot out there. You can even try Botox injections in the adductors, so unilateral or bilateral, and sometimes that works. So is there anything else? Well, you know, a lot of our patients are on OTC cough suppressants, and many will say it actually does help a little, and it's part of the picture. So I think it's not unreasonable to recommend those. Tessalon Pearls works with an entirely different mechanism of action, although we're not quite sure what that is, but 100 to 200 milligrams TID. Tussianex, which is, it's in the narcotic category. I don't use this very often for my patients, but it's hydrocodone and chlorpheniramine, which is a sort of older antihistamine. But for patients with nighttime cough that just can't, they just can't get sleep, I think it's a reasonable thing to use short term. And then one more thing that we use a lot, and that Laura talked about earlier, is the superior-laryngeal nerve block. And this has kind of changed our practice in a good way. So it's a peripheral nerve block. And so if you look back at peripheral nerve blocks, they've been around a long time. Actually, the first one was performed by Halsted using cocaine. This is in the late 1800s, and it was actually described in a textbook back in the early 1900s. But it kind of became a lost art during the rise of general anesthetics. And in the 80s, it regained some of its popularity. There was renewed interest. If you look at the indication for nerve blocks, it's really for pain management. Pain management doctors love using these nerve blocks, and then anesthesia to prevent either pain, or obviously a local anesthetic case, or gag reflex if you're trying to intubate the patient to do an awake fiber optic. Really not many other indications for this. So the way we came up with the nerve block, it really kind of started with this paper. And I'm sure a lot of you have heard of hyoid bone syndrome, which is kind of poorly understood condition where patients present with pain sort of over the greater corner of the hyoid bone, sort of posterior thyrohyoid. And it's thought to be tendinitis or tendinosis of the strap muscles where they attach to the hyoid bone. Not really well understood, but responds to corticosteroids. And this is a pretty nice paper by Adam Rubin it was a large series. And so I've used this for hyoid bone syndrome for a long time for pain control. And so when you look at the articles, this is the target on the left where they're injecting it. And I looked at it and it's like, it's kind of close to the internal branch of the superior-laryngeal nerve. And I had a patient come in with what looked a little bit like hyoid syndrome, but he felt something internal. He said, I definitely have pain inside my throat. He'd been treated with PPI, sort of aggressive reflux management, but he could still feel it. And I looked at it and I thought, I wonder if you just do a nerve block. It's probably the distribution of the nerve that he's feeling. So I tried, I think it was lidocaine with epi. It's all I had in the clinic, and it went away immediately. He said, it's gone. I don't feel the pain anymore. He was really happy. Came back a month later, still gone. So I thought, wow, that's interesting. So I was doing looking at some papers for a chronic cough talk, and I saw with TRPV receptor, there was an article on a target for the treatment of pain and cough, airway disease, and I wasn't real interested in the urinary incontinence part of that paper, but I thought it's interesting. So pain and cough have a common receptor. So I was like, I wonder if this would work for cough. So we started trying this. I talked to a friend of mine who's a pain management specialist, and I said, like, what do you use for nerve blocks, like when you do for back pain? So we talked a lot about it, and he came up with a sort of what we now use. Now, so we started thinking about this, and I tried it on some patients, and it worked on some, but this is like the classic patient that we'll see that it works on.
And then we'll go praying, and when I lean my head over, then it's right there. It's a little spot, and it starts to tickle or to be aggravated in some way. And so then I'm coughing.
That's the ideal patient for this kind of treatment. She can actually localize it, and she'll feel a tickle there right before a cough. So how would it affect neurogenic cough? And I guess Laura got sort of lambasted by some PhD pulmonologists at this meeting. I mean, it's some theory, but if you look at the sites of neurogenic cough propagation, it works on a number of the areas, sensory receptors, afferent nerves, and brainstem reflexes, indirectly. So it's not too hard to imagine how a stimulus in the larynx could be blocked with a superiorlaryngeal nerve block and might reduce the propagation of these cough signals. So this is how I do it. I use a cc of 0.5% Marcaine and a cc of Kenalog 40 and a 27 gauge needle. You can feel when the needle hits the thyroid membrane. You can actually kind of bounce off of it. But the footprint you're looking for is the posterior 1/3 of the thyroid membrane space. And there's actually a CPT code for it. They almost got rid of it, and fortunately the Academy leadership had contacted me and said, it's technically a vagal nerve block. And they're like, do we need to keep this around? I was like, I would, because I think people are going to be using this more. And fortunately, it's been maintained. It's, I think, around 1 RVU, and it pays about $60 to $80 Medicare. The way I would do this, and I think if you kind of distract the patient. A lot of them don't want a needle in their neck, obviously. So a lot of times I'll push with my third finger and really push hard on the contralateral side to push it over, and then they're kind of distracted by how much that hurts because you're strangling them. And then I'll put my thumb over that thyroid space posteriorly. You can feel it. It's obvious. And then I just track the needle down there till I know I'm over the space, and then I'll inject it. Beware, in really thin patients, you can go right through and into their airway, which I've done a few times. They're like, oh, that tasted funny. So you have to be careful. So you can use particulate versus non-particulate, and I kind of debated this with the pain management guy that I was talking to. Triamcinolone and methylprednisolone, they're both fine. I mean, if you have methylprednisolone in your clinic, you can use that. But this is the one, the steroid that gets released slowly. So I think it's preferable if you're looking to reduce whatever inflammatory reactions around there. And so in a meta-analysis actually shows a slight advantage of those over the regular non-particulate steroids when you look at least pain for epidural injection. So that's what we use. This is the way I inject it, and I actually got this from Peter Belafsky's nurse. We were visiting there, and he was seeing it. It was great. Laura and I were at his clinic, and this patient came in, and he hadn't tried a nerve block before, and we were talking it up, right? And so, I think he was slightly skeptical. And the next patient walks in. She says, I have this cough, and it's irritating right here. And she points right at the internal branch of the superiorlaryngeal nerve. And Laura and I are standing in the back going, block her, block her. And so he's like, all right, we'll try it. So his nurse came up with this system, which is great because you want to mix the two together. And so I took 2 3cc syringes, take 0.5% Marcaine and the Kenalog, and put a cc in each one, and you can get a connector to kind of mix them back and forth, kind of like you would with Flow-Seal or some of the, I guess, Symetra. So, and it's very therapeutic when you're sitting there talking to the patient and you're pushing that back and forth, and they're telling you all about their cough. It kind of calms me down. So it's like a fidget spinner for me. So we finally published this last year in the Laryngoscope, and this is a paper with me and 3 of my wonderful fellows, Laura being one of them, Mike Lockton and Kathleen Tibbetts. And it was a retrospective study looking at patients with suspected chronic neurogenic cough. The vast majority had the big 3 already treated, which we were talking about, reflux and asthma. and allergies. So these are people that were sort of a diagnosis of exclusion patients. The results with our 18 patients, before I share these results with you, the interesting thing was the mean duration of cough in these patients was 7 years. We had people that were up there 15 or 20 years, and those are the kind of patients that come in and you're like, I don't know if I can help this patient. And it's really discouraging when you see them. They've had the full workup, they're still coughing years later, but it can work on these patients. When we looked at our results, 83% of the patients improved, not a bad percentage. A good chunk of them did well with one block, and that's all they needed, but there's a pretty fair chunk that do return for serial blocks. But when we looked at sort of the aggregate, the mean CSI decreased from 24 to 15, not fixed, but better. So the ideal candidate I mentioned earlier, if they have, you would really prefer they have an irritable focus, like a tickle or irritation. Really, I like it to be in the thyroid space, but if it's anywhere around there, there's a chance they would respond. So I'm pretty liberal in recommending this. But if you have a trigger point posteriorly at the thyroid membrane, especially if pushing there elicits a cough, that patient's probably going to respond. Some get benefit immediately. They'll immediately say, okay, that feeling is gone, I'm better, and they walk out happy. But almost all of them, if they're going to get a response, will within a couple of days. It can last weeks, a week or two, all the way to months. It just depends on the patient. I have noticed that if people that get serial injections, you're usually able to extend the interval. So maybe 2 weeks at first, and eventually I have a lot of people that come in every 3 or 4 months for this just to maintain their... If I can't localize the side, if they can't really pick, I'll try one side, bring them back in a week or two. And if they had no response, try the other side. If they had no response with that, they're not going to. Side effects are really rare, generally minor. The patients will tell you, if you hit it, a lot of them will tell you, I definitely feel a numbness there. I have not, I guess Laura may have seen aspiration in a couple of patients. I've not seen that because it's only a part of their you haven't seen it? Yeah, I haven't either. So I usually tell them that they can drink immediately. I've not seen that as a risk for aspiration. We've had some people get short of breath, laryngospasm, especially if they come in with a history of laryngospasm plus cough, it could happen. Anytime you stick a needle in someone's neck, obviously they can get syncopal. I always draw back on the needle, right? If you've got a particulate steroid that could potentially embolize, you've got, you could give intravenous Marcaine and get toxic from that. I've never seen it, but I want to be careful because, as you know, with the nerve, there's the vessels going through that foramen, so you can definitely inject into that if you're not careful. So why the prolonged effect? And this is a great, I talked to this colleague of mine that did pain management for quite some time. I said, it doesn't really make sense that you're giving them an anesthetic that lasts 5 hours and yet they're getting long-term benefit. So he started kind of backpedaling. He's like, well, suppression of nociceptive discharge, it could be a blockade of the arc, the sympathetic arc, a blockade of axonal transport. He kind of was putting a lot of theories out there. I'm like, well, what do you think? He goes, well, I really think it's like rebooting your computer. So kind of a simplified, Control-Alt-Delete. And so if you interrupt these signals from the larynx or from the pharynx, where the irritation is coming from, and you can block them long enough, they may respond. You may get a change in their CNS. So that's why I like to use Marcaine. It lasts a little bit longer, so I think you get better effects from that. But it's never been looked at. So it's nice. We have a new treatment for cough. It's easy to perform. It really is within your wheelhouse, easily within your wheelhouse. It's low risk, really minimal side effects, and most people will get a response rather quickly. And there's a pretty decent chance they'll get better with this if you select these patients carefully. So sort of to tie it all up, we treat the big three first. Usually you're going to look at upper airway cough syndrome, asthma, and GERD. And then if you really kind of come to a dead end there, and that's really how a lot of patients already come to us, at a dead end. And that's why neurogenic coughs are really common in my practice. But it is technically a diagnosis of exclusion. Most of the time, honestly, if there is some sort of trigger in their laryngotracheal region, I'll do a block first. I'll mention neuromodulators. I'll say this is a pill that you have to take every day. Good evidence that it works, but we could try this nerve block and see what you think. You may be able to avoid the medication. And if it doesn't work, you still got the neuromodulators in your back pocket. Cough suppression with a speech pathologist. I can't emphasize enough. find somebody in your community that likes this. There's usually a speech language pathologist in the bigger cities that enjoy seeing cough patients and can really be very helpful. And you need help. You need help with this. It's hard to do it with just one modality, and that's why a lot of these patients are getting nerve blocks, seeing the speech pathologist, and it takes everything to kind of get their cough to go away. So get an SLP involved. If you have someone in town that does that, they can be very, very, very helpful. In fact, I always joked with my speech pathologist because when we really cured somebody with chronic cough, she was always the one that got Christmas cards from them, not me. So, that tells you what side their bread was buttered on. So that concludes our talk. If you have questions, I think we have probably a fair amount of time for questions. What time is it?
Oh, we got plenty.
Oh, we got plenty of time, so 50. So if you have anything, we'll field it. Also, you want to? Anything? Oh, thank you. I will say, and if you need to leave, that's cool, but I was talking to Peak earlier. I mean, if you're aware of the spectrum of symptoms with irritable larynx, which would be globus, throat clearing, cough, paradoxical vocal flow motion disorder, laryngospasm, muscle tension dysphonia, they all fit into that umbrella of irritable larynx. And I think at one time or another, Laura and I have tried a nerve block in any number of those patients. I've had it be really effective for laryngospasm when the patients feel a trigger before they get their laryngospasm somewhere in the sort of posterior thyroid space. That's been very effective. Now, some of these could be placebo, but like Laura says, that's not a bad placebo to have if it's working. Muscle tension dysphonia, they need to see a speech language pathologist, but a lot of my SLPs will tell me, when you nerve block them, it makes it easier for me to do my job. Like before I send cough patients, if they get a nerve block, that's what they'll tell us. Thank you. This patient's easier to deal with. At least we can get off to a good start because you've already sort of suppressed their cough, and now we can work with them a little easier. So I've used it for throat clearing. I've used it for globus. I wouldn't say it works very often for globus, but throat clearing, definitely, if you can find the right patient. Yes, in the back?
So, Tramadol, I've had a few patients who respond amazing to it, and they're coming back to this drug forever. And I try to pass them on to King Harrington, and they're like, this is ridiculous. So, how do you manage that, and when do you introduce it? I find myself trying Neurontin more, because I
Right.
don't want to get to the point where they like Tramadol.
Yeah, no, I agree with you. And I think it is probably, you could put in your algorithm as the very last one you would use of the medications. Fortunately, I haven't had many patients who are on it long term, but I do have a couple, and I do kind of feel uncomfortable continuing to prescribe this. A lot of them have told me, I just take it when I need it. They'll say some days I don't even need it, so I won't take the medication, or I'll just take it once a day or twice a day. But I agree, I also feel a little uncomfortable with those patients, and I think if I had a whole cadre of 400 of them, I would probably be like you. I would want to back off on it.
So, I did, our state had suggestions and regulations on narcotics, and so we signed a patient-physician agreement on
It's a great idea.
And I do find that I only think I have 2 or 3, and they do take it like once every 3 or 4 days. So it isn't a lot. It doesn't feel that bad giving, but
Right.
the agreement is how I solved it.
It's good. It's a great idea. Right. Well, every time we do this course, I learn something about cough I didn't know. Somebody's got some great ideas, so don't just feel like you have to ask a question. If you have ideas that you've used, sometimes we've even incorporated them into the course the next year. So, yes.
Do you ever use the capsaicin spray? If they have commercially available something called sinus plumber cough cold spray, that some patients who are not interested in medicine, it's basically like capsaicin and then spearmint and some other essential oils and echinacea. And some
Right.
people really like it.
Yeah.
You get it on Amazon or Ace Hardware.
Ace Hardware. So capsaicin spray was what she was talking about. I've never used it. Somebody had told me they tried it and actually made the problem worse, but I've definitely heard about the use of it, and it could be in your algorithm. I've just never used it. Yes.
I've used transtracheal lidocaine as a predictor for success for something like this before. So you have someone constantly clearing the throat, do some transtracheal lidocaine, numb them up focally, and then that can be they have a really good response to that. And that's, in my experience,
The neuromodulators work? Was that?
you're on the right track with something like this.
Oh, gotcha. Okay. That's great. Yes.
That allergic algorithm, I've mentioned it in passing, but I have found personally that montelukast
Mm-hmm.
a lot of the time.
Yep.
So you should keep that in your armamentarium.
Right.
It has very few side effects if then.
Good.
A lot of patients.
Yeah.
Yeah,
absolutely.
that's a good point. And I think there was another one right here. Do you had a cough? I'm sorry? Yeah, I ask him to localize it. I'm oftentimes palpating while I'm talking to him, and I'll ask him, "Do you feel a little discomfort here?" You know, aside from the fact I'm strangling you, and I'll go back and forth between the two sides and kind of palpate along the posterior border of the larynx and see if they can say, "Oh yeah," and sometimes they can go, "Yeah, okay, I do. It's a little more uncomfortable here." If they can describe it to me and the point, that's the easy one, right? And if that doesn't work, I'll palpate, and if that doesn't work, I just pick a side and just bring them back a week later and try the other side. It may or may not work. It's low risk.
Any challenge or changes in your technique for morbidly obese patients, where maybe palpation of the laryngeal landmarks are maybe
A little tricky. Well, I'm in San Antonio, and we don't actually have any obese people, so I have no idea what you're talking about. No. It can be a challenge to get down there, right? Because you're going through a fair amount of real estate. It's not really been a problem. And one thing, as I mentioned before, I'm kind of pushing the larynx from their contralateral side over. So you get a little, and then if you put your fingers down on either side, right, you've kind of eliminated some of that space. So I've not had it be a problem. I also realized that Laura I think she's about to tell me she has more fat patients than I do. So, so maybe you have some.
Yeah, I mean, I have had that problem. So usually what I'll do is I'll have them stay in the office for a few minutes, and I'll ask them, do you feel like your throat is numb? Because if they do, then you probably got the vicinity of the nerve. If not, then you may consider them, bringing them back a little bit earlier and see if you re-inject them and try a different trajectory or maybe the different side.
If you realize that that's 2 cc's, it's a fairly large volume, and maybe I should have started with 1 cc total. I don't know. It just seemed like the right amount. So if you get close, I think you tend to get a response. You do. So just the neighborhood, get in the neighborhood. If you nail it, it's great. But I think some people do great just with getting in the neighborhood. So yes. I'm sorry. Yeah, that's a great question. So the question was, any results without using steroids? I'm kind of afraid to change it, but a colleague of mine, one of my former fellows, said that when she's giving recurrent shots, like somebody that's coming in every 2 weeks, she will take the steroid out and just do the longer acting, the Marcaine, and she's had just as much success. So it may be, if they're coming in a lot, you do kind of worry about injecting Kenalog in that area over and over and over. And I've had a few people where I think it's placebo effect, and I'll just take it out because I figure Marcaine's pretty low risk in the grand scheme of things, right? So I have done that, and it's a good idea. And sometimes I think you're, especially in muscle tension dysphonia patients, I think the steroid does something. Maybe if there's a sort of a chronic sort of inflammation from, a lot of MTD patients will get pain right in their strap muscles, and sometimes I think you're just kind of helping that with the local anesthetic and with the steroid.
I have injected one patient who claimed she had an allergy to steroids, so we just did lidocaine, and she said, yes, my throat got numb, so we know we hit the right spot, and she had zero effect from the injection. So it's hard to say. She may be one of those patients that it's a little more complicated. It's not just clearly neurogenic. There might be a lot of things playing into it, so
yeah,
it's kind of variable.
Yes?
Any additional thoughts on the topic of the laryngospasm?
So the question's about patients that also have laryngospasm with their cough? Yeah, and that definitely happens. I think the neuromodulators and the nerve block are both effective for those patients. I mean, one may be more than another. But yeah, those are patients who are even more highly motivated to treat. I've had a lot of success with the nerve block for those patients. Yeah. But it's going to wear off. So the ones that I can think of that sort of come back frequently for that, and they'll come back and say, when this wears off, I'm right back where I started. Those patients, it seems like it tends to last about a month, 4 to 6 weeks, but it's well worth it for them to come in and get those shots. I haven't come for long distance, so that's hard to do. Any other questions? Thanks so much for your attention. Enjoy your hike back to wherever you're going.